right, welcome everyone. My name is Haley Buckner and I'm the Professional Relations Manager for Elevate Oral Care. Thank you for joining us this evening. Before we start, I'd like to cover a few housekeeping items. For those of you remaining online past 50 minutes, your CE certificate will be emailed automatically within a few hours of the completion of this talk, so be sure to check your spam folder. You are all muted, so no need to worry about background noise. And we will have time at the end for questions, so you can submit your questions on your webinar dashboard as they will be tracked throughout the talk. We have hosted an extensive series of free live CE webinars on many prevention topics. Each of these webinars were recorded and are available with free self-instruction CE at the web address that you can see on your screen, elevateoralcare.com/elevatingcare. Be sure to bookmark this page and return often to see what's new in free CE. If you have a topic that you'd like to see covered, feel free to suggest it by sending an email to info@elevateoralcare.com or by completing the webinar survey that will be sent after the completion of the talk this evening. In fact, tonight's talk is an example of this. Through our post-webinar survey, the topic of sleep apnea has been heavily requested, so we're excited to bring this to those that have been asking for such a webinar. So this evening, we are honored to have Dr. James Bieneman. Dr. James Bieneman graduated from Indiana University School of Dentistry, and after seeing all of the long-term health problems that his patients were experiencing, Dr. Bieneman became hooked on airway dentistry, including airway-focused orthodontics, obstructive sleep apnea, TMD, and tethered oral tissues. Continuing education on these topics became his passion. The interrelationship of these specialties and treating patients who are experiencing these problems has become the sole focus of Dr. Bieneman's practice at Integrative Dental of Denver. Dr. Bieneman is a diplomat of the American Board of Craniofacial Pain, as well as a diplomat of the American Board of Craniofacial Dental Sleep Medicine. Dr. Bieneman, the floor is yours.
Thank you, Haley. I appreciate it. Welcome, everyone, and I hope you enjoy this talk. And if you have questions, please let me know as we go along. I'd love to answer them all at the end and see how I can help. So sleep apnea has become this really big topic in the dental world, and understanding how it impacts our patients, our lives, and what we see in the dental world. So let's get into that. So as Haley said, this is who I am. I've done a lot of extensive training in pain and sleep. My practice solely now focuses on treating orthodontics, pain, so all the TMD world, obstructive sleep apnea, and all of the interrelationships of those topics. At this point in my life, they all are a spider web together of how they mingle together, and we can't separate them anymore in my world. So why does sleep matter? It helps everything from brain function, keeps our emotions in check, reduces disease. Sleep is one of the most critical things. It allows our body to heal. Sleep is when our body recovers. So if we're not getting good quality sleep, our body's not going to be in a good stage. And as a result of it, our body's going to do certain damage to ourselves because we're not letting it heal. So why should we care about sleep? There's so many things that we can see and that both our patients are going to be experiencing, and some of us may be experiencing ourselves. One of the most common things we hear is we're snoring all night long. In the dental world, we'll see bruxism, but it can be also a lot of fatigue and tiredness. There's a lot of health risks, such as high blood pressure, heart attack, stroke, cancer, diabetes, dementia, Alzheimer's, congestive heart failure. All of these issues are made worse or exacerbated or caused completely by untreated obstructive sleep apnea. So a lot of it is, how can we improve not only our long-term health, but also our quality of life, making it so that we have a lot of energy throughout the day and we feel like the person we want to be. The crazy thing is that we can see a lot of the signs and symptoms just looking in the mouth. When I was in dental school, we were told to look for certain things like, hey, if there's a little worn down tooth, we're going to fill the tooth. Hey, if a patient has grinding, we need to make them a night guard. But we're really been ignoring what's the root cause of the problem. So a lot of the things we're already seeing and trained to look for, now we just need to think of them in a different way to say, hey, what's really causing this issue? And when we start asking the why and looking at the root cause, we're going to start seeing a lot more. So what do we see in the dental world, right? Bruxism and grinding is probably one of the most common things that we see. How many patients don't have those, their cusp tips anymore? They're all flattened down, or they have worn down teeth, or they no longer have their lower front incisors and they're just completely ground down and they don't have any vertical opening anymore. How many of these patients have those notches, abfractions near the gum lines, and it's like, oh my gosh, they keep falling out, they keep breaking out. We just put this filling there 6 months or a year ago, and if we're not addressing why, we're going to be still doing the same thing. Lots of times we'll see huge fractured restorations. The other big thing is that tongue that a lot of us wish we could just cut out. If we look at it and say, how big is it? Is it scalloped? Do we see that on the tongue? That could be a sign of untreated sleep issues. Not including looking at what does our facial structure look like. A lot of people who have those deep overbites, or they have a deep bite in general, their mouth breathing, their bags underneath their face. Oftentimes when we look underneath in their throat, we look at the throat as something to get past and ignoring, and oh my gosh, is my patient gagging? But if we actually look in the patient's throat and look at what's called their Mallampati score, oftentimes we can see, hey, does this patient have a small airway? Those class 3 and class 4 airways are really big concerns for us. That, oh my gosh, is our patient's airway obstructing, and is it too small, or is there something causing it to collapse while we're sleeping? So, the crazy thing is we always think about the overweight, over 50 male as the person with sleep apnea. The crazy thing is that's no longer the paradigm. More and more, we're testing not just all those adults, we're testing all adults who have symptoms, but we're also looking at it to say, oh my gosh, these kids that we're seeing all day long have it. How often do we have kids that come into our practice and they're just running around crazy, behavior issues, problems? Parents are like, oh my gosh, this child is crazy. They're so high energy. And a lot of the times we may be looking past the real underlying issues. Kids can have sleep apnea as well. They can snore. They can have large tonsils. They can have a lot of behavior issues. Are they bedwetting past the age of 5? Do they have large overjets, mouth breathing? Do they have those bags underneath their eyes and allergic shiners? Does it look like they're just not really there? Really narrow palates with all those teeth that are just jumbled and crowded on top of each other, those are all signs and symptoms that we need to be paying attention to be looking and saying, hey, is this just a dental issue, or is there a bigger problem going on? A lot of the times we as dental professionals can look at these patients, both kids and adults, and see the problems and say, hey, how could we help improve this person's quality of life by addressing the underlying reason why they're having these problems? In kids, it's more than just, snoring and behavior issues. The crazy thing is that growth hormone, which is responsible for cognitive and physical development, is released only in the deepest stages of sleep. And kids who are having a lot of sleep disturbances are not going to get the proper amount of growth hormone released, which is going to cause decreases in cognitive and physical function, as well as, overall, they'll see decreases in IQ scores for these children. So it's really a long-term problem if we ignore it. So, and we get into the idea of, as dentists, we've been trained, hey, if our patient bruxes and they clench and grind at night, they need a night guard, right? Well, the question is now, is this really helping? Is this really the right treatment for these patients? And there's starting to be some research showing that, hey, when patients are given a night guard and they have untreated sleep apnea, it could actually make their sleep apnea worse. This is just one study that shows that 43% of patients had their apnea get worse as a result of using the traditional flat plane night guard. So really, before we're starting to make these patients night guards and just treating the symptoms, we should be really asking, hey, what's going on with this patient's sleep? Is there an underlying problem? And should we be addressing that problem first rather than just masking the symptoms? Don't get me wrong, it's really important. We want to protect those teeth, but is protecting the teeth really the right thing to do if there's an underlying bigger issue that should and needs to be addressed for those patients? So let's talk about it. What is sleep apnea? Right, so there's really a couple of different types of events that we're looking for. So if a patient were to do a sleep test, which is how sleep apnea is diagnosed, we're going to look for one of 3, maybe 4 different types of events. Let's start in talking with what is an apnea, right? The way I like to think of an apnea is think it's like suffocating. It's when our airway completely closes off for at least 10 seconds while we're sleeping, right? And so technically it's a 90% or greater reduction in airflow, but think of it like suffocating. No air is moving in or out. Our body is trying to breathe, but we're unable to breathe. Now, a central apnea is a little bit different. Central apnea is where, think of it this way, our brain stops telling our body to breathe. So there's no effort or no attempt of our body to breathe for that same 10 seconds or longer. So and we're oftentimes seeing a drop in our oxygen saturation while that's happening. So apnea, complete collapse, think it's like suffocation. Central apnea, think it's our brain is not telling our body to breathe. And then the next one is a RERA, respiratory effort related arousal. It's when we're starting to see a difficulty breathing, and we're going to see increased respiratory effort as we're going through it. The last one is a hypopnea. Now, the hypopnea has two different definitions recently. So let's go through both of those. The first definition is a greater than 30% or more decrease in airflow, combined with, it has to be at least 10 seconds. And now this is where the two differentiate between the first one and the next one. We'll go over the next one in a second. The definition 1A is a 3% or more drop in oxygen and or is associated with an arousal. An arousal is when our brain tells our body to wake up as we're sleeping. And the reason that that happens is because of the oxygen drop. As the amount of oxygen coming into our brain, our body and our brain drops, our brain starts to panic. It's like, oh my gosh, I'm not breathing, I'm not breathing, I'm not breathing. Our brain releases a whole bunch of stress hormones, adrenaline, cortisol, and those hormones wake us up. The first thing that they do is they take us from a deep stage of sleep to a lighter stage of sleep. That's the arousal event. The way I like to think of this type of event, the hypopnea, is think it's like trying to breathe through a coffee stir stick. You're getting some air in, not enough. So the second definition of hypopnea is this. So it's still that same 30% or greater decrease in airflow for at least 10 seconds. The difference is that this is a 4% desaturation, okay? And arousals are not part of the definition for this second one. So 1B was what was used for many, many years, and 1A was just introduced. So why does it matter, 3% versus 4%? So there's a couple of different studies that are going to show that the short answer is that more patients are being diagnosed with apnea if we use a 3% desaturation compared to a 4%. And how many more patients? Well, it really varies based on the study. On the low end is as few as 12.5% of patients. On the other hand, it could almost double the number of patients that are being diagnosed with sleep apnea. And why does it matter? So typically the 3% group tends to have a lot more symptoms, a lot more fatigue, tiredness, exhaustion. They're the ones that are dragging throughout the day. And so there's a bigger group of patients that we could be helping if we were using this 3%. So there's a big argument within the medical community that we should be using a 3% versus a 4% desaturation. And the reason I bring this up is if you start seeing sleep studies come across your office, you're going to see some physicians are using 3%, some are using 4%, some are using a whole different numbers. And so it's really getting into why does it matter? Now, let's talk about what the categories are, because this is what really matters. The first thing that you're going to see on sleep studies is what's called the AHI. So that's the apnea hypopnea index. So that in that regard, we're looking at how many events happen per hour. Between at 5 events, but under 15 events per hour is going to be mild sleep apnea. Moderate is going to be anywhere from 15 to just under 30. And severe is going to be anything over 30 events per hour. And the way I like to think of it and talk to patients is think of it from a different perspective. I often say, hey, if you have moderate apnea and I round it to, let's say you have 20 events per hour, that means every 3 minutes while you're sleeping, you're having one of these events where your airway is partially or completely collapsing, the amount of oxygen in your blood is dropping, and your brain is panicking and waking you up. How many of us want to be woken up every 3 minutes and having that arousal event while we're sleeping? That's why we have a lot of patients who are having fatigue and tiredness. Now, another number that you oftentimes see on sleep studies is the RDI. So that includes the apneas, your hypopneas, and those RERAs, those respiratory effort related arousals. So again, where you're having a difficulty breathing and it's causing an arousal event as a result of the difficulty with breathing. Now, the crazy thing is that some insurances are now allowing us to diagnose sleep apnea off of an RDI number versus the AHI number. The benefit of that is, again, it's going to be more encompassing and allow us to treat more patients because it's a broader definition of what is sleep apnea. And again, what you'll find is that sometimes you'll have patients who have a lower AHI and a higher RDI. Oftentimes those are the patients who are symptomatic, because as they're having one of those rare events, it's waking them up and giving them an arousal event so that their events don't become quite as severe. Now, that's the adult definition. In kids, the definitions become much more sensitive. In children, we look at it and say, and 1 to 5 events per hour is considered mild sleep apnea in children. 5 to 10 would be moderate, and anything over 10 events per hour is severe. So really that means if a child is having 1 event every hour that takes them from a deep stage of sleep to a light stage of sleep, they're not sleeping well. And then they're going to be at risk of developing a lot of these longer term health problems. And that's where the biggest issue is. Kids not only start developing all those long-term health issues that we see in adults, but the big one is untreated sleep apnea in children results in lower growth hormone, which is responsible for their cognitive and physical development. And we're going to see a lot of more behavior issues in these children, in addition to fatigue and tiredness. Oftentimes these kids are diagnosed with ADHD. Right? And why is that? If you start looking at the signs and symptoms of pediatric ADHD and pediatric sleep apnea, they're almost identical mirrors of each other. And it's really hard to tell which is it. Is the child having problems focusing and concentrating because they're tired, or is it true ADHD? There's a lot of research that shows that somewhere between 25 to 50% of children diagnosed with ADHD have an untreated sleep issue. Right? So when we start looking at it, a lot of these signs and symptoms are very, very close to each other. And how do we tell the difference? Right? So when we start looking at it, in kids, there's a lot of factors that show, as high as 30% of children with obstructive sleep apnea have ADHD. And so there's a lot of overlap between these two that we have to be looking for. There's more research, so much research that correlates these two, that obstructive sleep apnea and ADHD in children are very similar. And here's the other thing, obstructive sleep apnea may contribute to making ADHD worse. So we have to really be looking at it and saying, should we be putting kids on medication, or should we be trying to address, again, the root cause and the underlying reason? Right, so there's a ton of research also showing that the interrelationship between ADHD and sleep apnea is so hard to differentiate between, that many providers are unable to differentiate between the two without a sleep study. So really, again, it gets down to, before we start medicating and going into that direction, we should really be asking, is it sleep apnea or is it true ADHD? There are both. And the crazy thing is that snoring is a big factor in this too. How many kids snore while they're sleeping? There's a huge association of snoring with ADHD and other sleep-related disorders. Right? So this is where we have to ask, how much of the issue is airway issue versus is there a real ADHD issue going on? So this is where it's gotten to the point that even the American Academy of Pediatrics has said any child who snores on a regular basis should be screened for sleep issues. And the crazy thing is that even without a diagnosis of sleep apnea, snoring was correlated with poorer academic performance in kids. So this is where even snoring needs to be treated and addressed with kids. Now, how do we address sleep apnea, right? And this slide alone has so much information, and there's so much details in here that I could spend a whole week talking about these topics. But let's go over this from a high level real quick. If we have an adult who's been diagnosed with obstructive sleep apnea, the first thing that physicians are going to typically recommend is some kind of PAP therapy, CPAP, BiPAP, APAP. They're the gold standard in managing sleep apnea. A CPAP works by forcing air down your throat to keep your airway active. It prevents our airway from collapsing while we're sleeping. If a patient is using a CPAP, BiPAP, or any of these kind of PAP machines, everybody will acknowledge that for the most part, most patients are going to have their sleep apnea properly managed by that CPAP machine. Now, the reality is that compliance with these machines is much lower than everybody wishes, which is why we have all of these alternatives. Now, the one other characteristic or thing to describe is that there's a whole separate machine called an ASV if you have a high percentage of central apneas. As dentists and in the medical profession or in the dental profession, we're able to help patients with obstructive sleep apnea when their airway is collapsing. Central sleep apnea is a much more challenging piece that needs to be managed medically. And so that's where the ASV machine is really the way to go for patients who have high levels of central apnea. And so when we're looking at those sleep studies, we have to be making sure that we're managing obstructive apnea, not central. So while CPAPs are great, they're not the be-all end-all for every single patient. This is where in the dental world, we can talk about what's called the mandibular advancement device. These appliances, and there's a ton of them on the market that are all FDA approved, are really good and really designed for mild to moderate patients. Now, and I say that because the lower the apnea score, the easier it is for an appliance to manage a patient. Now, the reality is that there's a lot of patients who have severe sleep apnea who are intolerant or unable to use a CPAP. As a result of that, that's where mandibular advancement devices can be a great alternative and options for those patients. The difference is we have to have different expectations for those patients in terms of what are we going to be able to achieve for them in terms of managing their sleep apnea. You know, most of the time when I'm talking to patients who have severe sleep apnea and we're talking about managing it with a mandibular advancement device, I say, hey, if we can get a 50% reduction in your score, that's a great day. We're not going to be able to fully manage everyone's severe apnea with a mandibular advancement device by itself. Now, there are a lot of other aspects and other things that we should be talking to our patients about as well. Weight loss is huge for our patients. On average, a 10% loss of weight is correlated to a 25% reduction in score. Now, that holds true until we hit about normal BMI. So that's not it's not to the extent that you should be telling everybody to lose weight, lose weight, lose weight, even once they're at a healthy weight. We can still have apnea at normal weight. Again, this is no longer the disease of the overweight, over 50-year-old male. There's so many patients who I see who are very athletic and they have no weight to lose. It's from other issues. After we get past mandibular advancement devices, the next thing is Inspire, which is a glossopharyngeal hypoglossal nerve implant that can help stimulate our tongue to be up and forward. This is something that we can have patients talk to an ENT about to see if they would be a good candidate for it. And so there's a lot of things a lot of reasons we may want to consider referring to our medical colleagues, especially ear, nose, and throat physicians and board certified sleep physicians, to talk about all different aspects of sleep apnea for what are the surgical options, what are the different things that we could throw at a patient to help them manage their obstructive sleep apnea. And one of the biggest ones we need to talk about is nasal breathing. And we'll come to that later because nasal breathing is really critical for being really effective, not only with the devices, whether it's a CPAP or a mandibular advancement device, but also helping to reduce the symptoms of sleep apnea, such as fatigue and tiredness. So when we start talking about mandibular advancement devices, there are so many appliances on the market, and a lot of them are very similar designs to each other. So if we talk about some of the main designs, there's the big one a lot of people have heard about is dorsal. They're the ones that have a little wing on the sides. Herps appliances, which have rods that are telescoping that go in and out. Tap appliances, which interlock with each other and allow patients to move side to side a little bit. EMAs, which have elastic bands on the sides, which help patients move side to side and give them a lot more range of motion. And then there's the Panthera appliance, which is a 3D printed nylon appliance, and there's more appliances are becoming 3D printed, which is great with this nylon because they're nearly indestructible. And all of these appliances have a place. There is no one perfect appliance for patients. So which appliance should I use, right? Again, the biggest thing is you have to look at the patient to figure out what's going on. Does this patient have a TMD issue? Well, some of these appliances, like a dorsal appliance, may be a bad one. If they're a grinder, you don't want to put them in something that has wings that prevents them from moving side to side. Those patients are going to wake up with more headaches at the end of the day. Do they have enough teeth? What teeth are present? If they don't have enough posterior teeth, you can't use something like an EMA, and you may need to use something with acrylic. How destructive is this patient on appliances? Are they a heavy bruxer? If they're going to be destroying appliances, maybe you want to go to that 3D printed nylon because it's going to be a lot more challenging to break that. How large or small is their mouth? If they have a really narrow mouth, like we've had bicuspid extraction cases, you may not want to use a thicker acrylic appliance. You may want to use a smaller, thinner, slimmer one like the EMA. So this is where there is no perfect appliance for every single patient. We have to look at the patient and really decide what's the right appliance for this patient. And so part of it is really doing a full, thorough exam to make sure that we can figure out how we can help our patients. Now, the other thing is when you start talking about using mandibular advancement devices, there are things we need to consider. All oral appliances have a potential to permanently change the bite. Is this acceptable? What's the lesser of two evils? Is it better to have a bite that's shifted a little bit or to have untreated sleep apnea, right? And so for some patients, they're willing to accept that their bite might shift, but it's going to help reduce their long-term health issues, help them feel better, and more energy throughout their day. These are just conversations that we need to have with our patients because these are all real risk factors. All oral appliances have the potential to cause facial pain if we don't do it properly. And even if we do everything properly, so a small percentage of patients may still develop jaw pain, which we then have to manage and reduce and figure out how to manage that pain and get them back to a nice, comfortable position. Just because a patient develops a little bit of pain as a result of the using the appliance doesn't mean that you did anything wrong. It's just, okay, how do we eliminate that pain? How do we manage that pain? And how do we get that patient back to the best possible position to get them out of pain while still managing their apnea? And the other thing is, depending on which appliance we're using, not all of these appliances are perfect retainers, and so some teeth might shift just a little bit. So it's really important to talk to our patients about all of these different factors and warn them, because there's a lot of things to consider, and some patients may be willing to accept it, and some patients might not be. And this is where we get into that a real big conversation in getting back to the night guard piece. The more we open patients when we make these appliances, the more the risk increases that we're actually closing off their airway. So there's starting to be studies showing that, hey, the wider open we hold the patient with their oral appliance, the more risk of closing off their pharyngeal airway and increasing their collapse. And that's why a lot of people believe that those traditional flat plane night guards may be making some apnea worse, because we're actually opening their bite, rotating their jaw down and back, and pushing their tongue more into their throat. So we have to be really careful about how we make these appliances and what we're doing with them. Now, why would you consider using an appliance even with all these considerations we've just talked about? Well, more patients will appreciate an oral appliance compared to a CPAP. There's higher long-term compliance with oral appliances than CPAPs. The other piece of it is, if you're able to use an appliance, we can really have a drastic improvement on the quality of life. How can we make it so that you have more energy, that you're less tired throughout the day? I've had some patients that when their appliance is broken, they're like begging me, they're like, I can't send this back to the lab to have this repaired. I need to have this today. I can't sleep without this. I need this tonight. What can you do for me? Which has then led some patients to almost have two of these appliances just for that situation of, well, if they're traveling, they don't want to forget it. If one breaks, they want to have a replacement or a spare. They really don't want to be without these because of how much improvement they have noticed in their life. It is drastic for these patients. Now, from our side, is in the dental world, we'll oftentimes see that the dental work we're doing is going to last longer. If patients aren't bruxing and destroying this all night long, those crowns aren't going to break. They're not going to break the porcelain off. The fillings aren't going to shatter, right? We're going to see better outcomes for all of our work. And the other real big benefit to patients is that more often than not, medical insurance will have coverage for oral appliance therapy, which means that patients can use their medical insurance to help cover the costs of this. The crazy thing is that a lot of times for many of my patients in that fourth quarter, especially November and December, we have a lot of patients who come in, they've met their out-of-pocket maximum for the year, and their cost of therapy is little to nothing at all, and medical insurance is covering it. Those patients are really happy. So it's a lot of just talking to these patients about how can we help them, and again, use their benefits that they already have. Now, one of the new areas that people are really exploring and talking about more and more is, can orthodontics help adults? And the answer is, we believe so, but there's just not as much literature out there published that we would like. There's some evidence that expanding the palate and creating more room in it can create more room for our tongue to go up and forward and allow our airway to open. I've had a lot of patients where we've done expansion on them as adults and they've stopped snoring and their apnea has reduced or gone away completely. So, but it's one of those areas that we have to have a lot of conversations about, because it's not so simple as, yes, you do orthodontics on a patient and their apnea goes away. On the other hand, when we start talking about bigger cases for patients who really want to try and eliminate it, that's where we can have a long conversation about maxillary mandibular advancement surgery. Done right, there's a lot of literature showing that it can reduce apnea in 86% of patients, right? So there's a huge success rate when this surgery is done right. And oftentimes it's combined with braces before the surgery, some expansion, and then the surgery, and then braces afterwards to bring it all together. But this is a much larger conversation to have with patients, but it can also be a very life-changing event for these patients if they're having severe apnea or any kind of apnea that they want to try and eliminate. Now, what about in kids? Again, when we start talking kids, the first line of defense for kids with sleep apnea is to talk about a tonsil and adenoidectomy, right? This is what the medical world wants us to look at as the first line of treatment for kids. Now, the question is, how effective is it? We're going to go into that next. Now, some kids will also be prescribed a CPAP, right? And that, again, we talked, if you're using a CPAP, we're going to know that your apnea is being managed. But are there any drawbacks of a CPAP? And again, one of the most important things is we need to help establish nasal breathing. And so that for kids is oftentimes referring to an ENT, an allergist, and looking at considering nasal sprays. Why are we unable to breathe through our nose? Is it that we have a deviated septum? Do we have swelling in our turbinates? Or is it more of an allergy? Do we have seasonal allergies, allergies to food? What is causing it to make it so that we're unable to breathe in and out of our nose? Now, this is for adults and kids. We have to establish why and fix and address the underlying reason why we can't breathe through our nose before we can start moving in the right direction. Now, one of the big things is for kids, improper craniofacial growth is the real problem for most kids in the absence of obesity. And this is where orthodontics for kids becomes the solution. If we can grow and develop their face and their airway to the size and shape it was supposed to get to, we can really eliminate sleep apnea in kids. And now this is an area where expansion is great. And expansion is one of the critical things we have to talk to all families about. If we have too narrow of a palate, there's no way our tongue is going to be able to live in the roof of our mouth. The problem is that no amount of expansion corrects an anterior-posterior lack of growth and development. So that's where we get those kids who have those class 2. We really need to focus on how do we bring the bottom jaw forward. Or is the kid also deficient maxillary? Do we need to bring the top jaw, the maxilla forward and the mandible forward and create anterior growth and development in kids as well? So when we look at it, the biggest problem is that kids are just really not adherent to CPAPs. It's a big problem for kids. So we really have to say, what are the other ways of doing this? And here's the other problem with it. Again, is there a problem with CPAPs for kids? Yes. CPAPs in kids can cause our face to move backwards. And so it only takes about 6 months of use for us to find that the maxilla and the mandible can be moved posteriorly in kids using a CPAP, which can then make the airway smaller. But what about tonsils and adenoids? And so this is where there's a really high effective rate of successfully treating kids with sleep apnea by removing their tonsils and adenoids. This study shows almost 83% effectiveness by removing the tonsils and adenoids. Now, almost 83% is a really high number, but this is where we need to also say, okay, let's first get the kids for having their tonsils and adenoids removed, but we also need to address the underlying root cause, which is, again, in the absence of obesity, our face did not grow as wide and forward as it should have, so we should be considering orthodontic treatment earlier, right? And so again, untreated sleep apnea with kids, this is a great thing where tonsils and adenoids can be a very effective option for them. But the success rate varies. This study shows it's going to be closer to about 60%. But research is showing us that in the absence of obesity, that our face not growing as far forward and wide is the problem. And so as in the dental world, we need to be looking at these kids and saying, okay, do they have a narrow mouth? Are they retrognathic? Is it just that their mandible's recessed, or is their maxilla and mandible back? If it's a class 3 patient, when we're out, is it really appropriate to bring the mandible posterior, or should we be bringing the maxilla forward more? There's a lot of research showing that the more we bring that top jaw maxilla forward, the more we're opening up the airway long term. So what happens when we start helping kids and adults with expansion? As we expand the roof of our mouth, it actually becomes easier to breathe in and out of our nose. Remember, the roof of our mouth is the floor of our nose. That's what I'm talking to patients about. And so as we expand the palate, we'll oftentimes find it's easier to breathe in and out of our nose. And I've had both kids and adults tell me this. I've had adults tell me, oh my gosh, I've never been able to breathe out of the side of my nose until we did that growth and development, right? So this is where we really need to focus on how can we expand. The more room we expand, the more able we are to get our tongue to live up and forward. The more we get our tongue up and forward, the more we're clearing out our throat. And this is oftentimes where I'm talking to patients about working with what is called myofunctional therapy to retrain their tongue to be up and forward instead of that down and back. We really need to make sure that if we do this expansion, that we're able to take full advantage of that space by training proper oral posture, tongue up and forward, lips sealed, and breathing in and out of our nose. Now, this is where mandibular advancement, we talk about bringing the mandible forward. Bringing the bottom jaw of the mandible forward can really be an effective treatment for kids with sleep apnea. So we really have to look at it and say, we need to not just address expansion, but also that anterior posterior dimension of space. But maxillary expansion can really reduce or eliminate sleep apnea in kids. We don't want to ignore expansion. That needs to be critical. And this is where the research in adults is starting to come out and say and show in some cases that expansion can help adults as well, right? So there's just a lot of research showing it that we need to be expanding. We need to be addressing the root cause, which is a smaller airway. Now, again, we talked about, do we want to be bringing everything forward? And so this is where we show that as the top jaw, the maxilla was moved forward, the upper airway is increasing, right? So we need to be looking at not just how can we manage the apnea in kids with tonsils and adenoids, but if we can move the maxilla forward, we can open up that airway even more, right? And so there's lots and lots of research starting to show that. So can airways be improved? There's absolutely. So as we move the maxilla and the mandible forward, we can have really large increases in that airway space. And so this is where it's critical to be looking at it and saying, how can we improve the airway by moving everything forward and wide? Now, what about nasal breathing versus mouth breathing, right? And so this is a real critical area. How we breathe matters, right? And what we've seen for a long time is that it's not just breathing is breathing. Mouth breathing leads to changes in how our face grows and develops. And that's where we'll oftentimes see that our face grows longer instead of forward when we're mouth breathing, right? And this has been known for many, many years. If you look, this was published in 1981 by McNamara about the effects of mouth breathing, right? So look at how long ago that was published. We've known this. And so now it's, hey, we need to start treating this and addressing this. Now, the bigger thing is that when we start talking about how effective are all of our treatments, right? Whether that's a mandibular advancement device, a CPAP, how effective are they? When we are breathing through our nose, we have lower resistance, which can really reduce our sleep apnea, okay? And so we really need to be making sure that we're focusing on nasal breathing versus mouth breathing. And this is where we're going to show that that nose breathing can actually reduce or eliminate sleep apnea in some cases, and where mouth breathing can actually make the symptoms worse or cause sleep apnea in patients. So we really need to focus on it. So, and here's the next piece about it. You know, we found that as we get patients to close their mouth, keep their lips sealed, mandibular advancement devices are more effective in managing sleep apnea for adults. So this is where we need to be real critical about, okay, is my patient mouth breathing? Is my patient nasal breathing? How can we do that? how can we get them into the right direction? It's not just about, here's your appliance, you're on your way. Patients are going to have better effective outcomes. They're going to have lower symptoms as we start addressing the nasal breathing, right? And so this is where it really gets down to, even addressing those nasal breathing issues. Nasal surgery can reduce the therapeutic pressure needed from a CPAP, right? So some patients they're able to use a CPAP, but they're not able to tolerate the CPAP at the higher pressure. So if we can get them breathing through their nose by fixing anything and any issues going on in there, it's going to make their CPAP therapy more effective because they're going to be able to use it at a lower pressure. So really, it's focusing on that. So how do we address nasal breathing versus mouth breathing? A lot of the times we're going to start talking to patients about, is this a habit or is this an obligate issue? If it's just a habit, meaning that we're just habitually having our mouth open, whether that's daytime or nighttime, then we need to start addressing that. And oftentimes I'll have families work with some combination of either myofunctional therapist or a buccal breathing therapist to help retrain nasal breathing, lips sealed, tongue up and forward. At night, sometimes we'll talk about, believe it or not, putting a little piece of tape over our mouth to force us to keep our mouth shut. And that can be a really effective way of forcing us and keeping our lips together, just because naturally some people's mouth will just fall open as they're sleeping, and the tape will hold it together. Now, the other thing is, are we breathing through our mouth because we are not getting enough air in and out of our nose? So for some patients, it's, do they have some nasal valve collapse? So one of the things I'll do with my patients is I'll say, all right, go ahead, sit there comfortably and breathe in and out of your nose and take some normal breaths. And then I'm going to touch them right here and I'll tell them, and I'll lift up and out and ask them, is it easier to breathe now that we've held that area up and out? As we do that, if so, it shows us that we're having some nasal valve collapse. And then, I'll oftentimes have them try like those breathe right strips at home and see, does that help them breathe easier overnight and feel more rested? If so, then hey, let's go talk to the ear, nose, and throat doctor about ways that they can make that more permanent. On the other hand, if our patients are obligate mouth breathers, okay, why? Why can't we breathe in and out of our nose? Do we need to use nasal sprays like Nasacort or Flonase if patients are willing to do a corticosteroid, or if they want to avoid the pharmaceuticals, try Xclear, which is saline and xylitol to try and reduce it. And using those can help promote drainage and get it so that we're breathing in and out of our nose. For some people, it's just congestion. On the other hand, again, do we need to go to an allergist? Do we need to talk to the ear, nose, and throat doctor about why we're unable to breathe in and out of our nose? Sometimes it's just getting on medications for like allergies. Other times it's, do we have to fix a deviated septum? Is there an underlying reason why we are having this problem? But what do we see in mouth breathing in our world, right? In a dental world, we're oftentimes going to see those patients who have a lot of dry mouth. They're going to have increased levels of caries and decay. A lot of these patients have big gingivitis that we've never been able to get under control, no matter how much we talk to them about brushing and oral hygiene and flossing, all the products we're using. Now, those products are great to help mitigate the effects. On the other hand, if we are not looking at the root cause of the issue, we're really not helping our patients long term. And so this is one of those areas where if we start seeing that our patient is mouth breathing all the time, can we get them to the right provider, an ENT or an allergist, to try and figure out what's going on? Or is it that we just need to retrain the habit? Myofunctional therapy can be very effective at teaching us keeping our lips together, tongue up and forward, and opening our airway. Right? So what can we do to help? Again, if we're having those experiences of patients with high caries rate as a result of the mouth breathing, using a high fluoride toothpaste can be a very beneficial thing to, at least in the short term, help them. If they're having the dry mouth is one of the biggest complaints I hear from my patients who are having sleep apnea. So it's, hey, if we can help them get their tongue up and forward, lips together, we can help reduce that. But in the interim, what other products can we use? So a lot of it is just helping to mitigate the symptoms while at the same time really addressing the underlying root cause of why we're having this problem. And so this is where I think it's a really big issue. If we're having difficulty nasal breathing, really consider referring to an ear, nose, and throat physician in your area to figure out how we can help our patients breathe better. So do you want to learn more about this? There's so many different places we can learn more about sleep apnea and all of the effects of breathing on our patients. I think these are some of the great resources that are available for where we can go and learn more. So I would strongly encourage you, go out, ask questions, learn, find more providers. All these different organizations are putting on CE, looking to give out information as well. We really want to help. This is where you can learn how to help your patients long term. Well, thank you so much for your time this evening. I really appreciate it. And if you ever have questions, feel free to send me an email. But what questions do you have that I can help with at this time?
Questions that have come in. Just want to make sure you're on here and able to hear me okay? Okay, perfect. So the first question that came in was, how often do you feel that sleep apnea in children is misdiagnosed as something else?
I would say more often than not. A lot of the times I find that kids are given ADHD medications, they're being given pills rather than looking at the root cause and trying to figure out why. We see it a lot in the orthodontics. There's a lot of things that, the crowding teeth, the deep bites, class 2, the underbite. We see a lot of symptoms. So I think that more often than not, you'd probably see it be missed because we're really not looking to ask the question why.
Great, thank you. Okay, and then a couple of questions came in about the Mallampati score, and I might have butchered that a little bit. Is the patient laying back or sitting up when you're doing that?
Sitting up, and typically it's like tongue out asking them. So always sitting up though.
Perfect. Okay, and then some questions about insurance came in. Have you had any luck with medical insurance paying for sleep studies?
Yes, however, let me be more clear about this. Medical insurance will typically cover sleep studies. I don't order sleep studies in my office, and so because it's so difficult to get them covered through medical insurance as a dentist. However, in most states, dentists can order the sleep studies. I prefer to just have the physicians order it, mostly because then the patient gets coverage for their sleep study.
Great, thank you. Okay, and this person said that they have found that mandibular advancement devices eventually permanently advance the mandible. Do you explain that to patients that they may need ortho due to that? And are you seeing that?
Absolutely. So bite changes are a risk of mandibular advancement devices for sure. I wouldn't say that it's all patients, but I do think that there's a fair number of patients that will experience a bite shift. And so this is where we then start getting into the long conversations with patients about, okay, what's more important? Which way do you want to go? There is no one way to always manage sleep apnea. If a patient is intolerant or unable to use a CPAP, then it's a really long conversation of what's more important, having your teeth come together or managing this disease process of sleep apnea. Untreated sleep apnea will increase your likelihoods of a lot of long-term health problems. If your bite doesn't line up perfectly and your teeth are off just a little bit, yes, I'm a dentist and I want teeth to be perfect, but at the same time, we're not going to die from our teeth not lining up perfectly. So orthodontics can be something to fix that if needed long-term.
Great, thank you. Okay, and then this person said, is a class 3 bite, which developed after 18 years of age from a person unknowingly advancing their mandible in order to breathe better? Would you say that?
Better than what, I guess, is the question. Typically, the nice thing in class 3 patients is that their mandible has grown a lot further forward than take like a class 2 patient. So they typically do tend to have better airway. So in a choice between being class 3 and class 2, I would take class 3 all the way. It's easier to fix a class 3 in a kid. It's better airways for an adult as a class 3 versus a class 2. So yeah, I would choose class 3.
Okay, and then you touched on this with children and CPAP machines, but this person said that they feel most children just get their tonsils and adenoids removed rather than CPAP machines and other things. Is that what you would agree with as well?
I would agree with that. The tonsil adenoidectomy is a pretty routine procedure for ear, nose, and throat physicians to do, and most kids tolerate it pretty well. I think that the success, close to 83% of either drastically reducing or eliminating. I think it's easier for kids to do that than to go on a CPAP. Now, I say that, and I will say that while tonsil adenoidectomy is always something I recommend if I suspect any kind of sleep issue for kids or there's a diagnosis of apnea, it's only addressing the symptoms. I joke, it's like roto-rootering out the pipes. It's not making the pipes bigger, which is where we have to look at the root cause and say, hey, is the airway small to begin? Should some kind of airway focus or growth focus orthodontics be done even after having the tonsils and adenoidectomy, because they can grow back still. So even though you take them out now, they may still have some regrowth or swelling later down the road.
Great. Awesome. Well, those were all the questions that came in. A lot of them were just right in line with each other. So thank you for taking the time to answer some of those questions as well. And really just thank you for a wonderful presentation this evening. And we thank you all as well for joining and spending your Tuesday evening with us. We do apologize for the background noise, and that is something that we will prevent in the future. But to all of our guests, your CE certificate will be emailed automatically within an hour or two. So make sure you check your spam folder. And be sure to follow us on Facebook and Instagram for links to new free CE events. That link that you see on the screen will give you access to our archived webinars, including this evening's webinar, which should be accessible in just a few short weeks. So please be sure to share this link with your staff and colleagues. Finally, on our Elevate Oral Care website, you will find buttons to request an informative CE-eligible staff meeting for your office. Education on the latest evidence in oral health prevention is what we do, and we would be honored to meet with your team and help you best serve your patients. So thank you and have a wonderful rest of your night, and we hope to see you on the next Elevating Care webinar. Thanks, Dr. Bieneman.
Take care.